Hello, and welcome to Grand Rounds in February of 2021. Today we have Dr. Steve Betz talking to us about applications of sleep hygiene in rehabilitation. Dr. Betz earned his Doctor of Physical Therapy degree from the University of Pittsburgh and completed his residency training in orthopedics at St. Luke's University Health Network, where he served as chief resident. He has been working with orthopedics his entire clinical career and has developed a specific expertise in patients with chronic pain and the use of sleep hygiene to augment physical, pharmaceutical, and cognitive therapies. Through this expertise, he has become a significant resource for his colleagues and patients alike. In addition to clinical practice, Dr. Betz has served as adjunct faculty for the University of Pittsburgh and the University of the Sciences in Philadelphia. For CME and also for continuing education credit, make sure that you are logged in as you so that I am able to send you the link to my e-learning. And if you are watching this from the recorded aspect, make sure you search for it on my e-learning to register yourself. So without further ado, I will turn it over to Dr. Betz.
Good afternoon, everyone. We are going to spend some time today talking about how sleep hygiene can apply to rehab and some of the different ways that we're going to be able to start to use some of those tools, hopefully even this afternoon if an opportunity presents itself. So we're going to dive right in if we can. So we've got a couple of slides here to kind of go through all of the fun stuff that we are supposed to include, such as, the fact that I don't have any disclosures. And let's talk through some of our objectives for what we're going to try and do today. So we have a couple here. The goal here is to basically summarize how an individual's quality of sleep can be affected, summarize what an individual's quality of sleep can affect in them, and then appreciate the relationship between the idea of sleep and the larger concept of cognitive behavioral retraining. And then we're going to talk specifically about this term sleep hygiene, what that means, why we're using it, why we call it that, and what we can do with it. And then we want to adopt some of those techniques into our own practice so that it's practical and helpful. So before we go any further, I would not consider myself an expert on the topic of sleep in particular. As you can see, I have upcoming fairly soon at the end of April here, a very good reason to be a very motivated student on the subject of sleep and or the lack thereof that I'm about to experience. But we joke, but the truth is the goal here is not for any of us to become sleep scientists, right? The goal here is for myself and the rest of us talking on this conversation to be able to use the ideas of sleep science in rehab. How does that apply to what we're trying to do? Why is it relevant? How can we use it effectively, right, as we control some of our patients' more complex circumstances and conditions? How can we use this as a piece of our arsenal? Right. So just that caveat aside, right, the goal isn't to talk about the science of sleep. The goal is to talk about the application of sleep today. And I think that's an important distinction. We're going to use a case example and thread it the whole way through as we go along here. So I'll introduce you. This is Cindy. Cindy is a 56-year-old female. She has a history of significant injuries to her brain tissues, both surgical and traumatic. So for a little bit more clarity here, when Cindy was young, up until the point she was about 20, 21 years old, she had upwards of several hundred seizures throughout the course of her young life. And eventually that led to a several step process to remove a significant portion of her left temporal lobe. since that procedure in her early 20s, she has had 0 seizures. So that was very successful. However, it has left a significant impact on her ability to have what we'd consider, and we'll see some of that play in. She's communicative, she can understand, she has appropriate motor control, but there's these sub processes, these things that are very challenging for her, and we'll dive a little bit more into that later. Additionally, she's had multiple concussions. Now she lives alone, she's on disability, and she's dependent on neighbors and other friends to make it to her appointments and even to go run some of her errands. She doesn't own a car, and she has an extensive comorbidity list, including things like diabetes and anxiety and depression, in addition to the neurological concerns we just talked about. Her original complaint when she came to see me was neck pain with headaches, which then transitioned into 10 out of 10 rib pain, which transitioned to unrelenting low back and hip pain, which somewhere in there transitioned back to neck pain, et cetera, et cetera. Constantly chasing these symptoms, right? And I'm sure I am not the only one who's had a patient like this. Where do you start, right? We've spent a lot of time over the past couple of years in the therapy world, especially in outpatient orthopedics, but even broader, trying to understand and assimilate the idea of educating and coaching and helping to retrain people's thought processes regarding their pain. And when you have some sensitivity of the central nervous system, what do we do with that, right? So we're going to get into a little bit more of that, but this is kind of where we're starting with our case today, and we'll revisit her in a moment. So I'm going to ask the question for you. Why would I care about how my patients sleep, right? Well, sleep is defined a lot of different ways in the literature, but this one I really liked. Sleep is a behaviorally regulated drive that broadly serves to maintain homeostasis and optimize function across multiple physiologic systems. So some of those functions include, and obviously this list could be a lot longer, but these are some of the really big ones. Immune system support. So the quality of your sleep is associated with decreased mortality or increased mortality if you have poor sleep. And sleep loss is actually directly associated with antibody levels and endogenous immune system chemicals. When you sleep, you also have a reduced caloric need. Your body enters this sort of like reset phase, almost like gets a chance to recharge itself, because your metabolic level is actually significantly lower. And that's true in all mammals, not just humans. Because of that, your brain is able to actually restore its glucose stores, right? So there's this decreased reliance on ATP to be able to create an action potential in a neuron when you're in non-REM sleep specifically. And because there's that decreased need for that metabolic function, the body is able to restore glucose supplies so that when you are awake, you're operating at peak efficiency. And then there's this improved glymphatic activity. And if any of you don't remember what glymphatic activity is from neuroscience, whenever the last time you worked on that was, that just means removal of wastes and toxins. So metabolic byproducts, lactic acids, but also other nasty chemicals like the amyloid beta proteins related to Alzheimer's. Those are all cleared significantly more easily while we're sleeping, because the pressure in our brain from the decreased metabolic load, our brain actually literally shrinks a little bit inside the cranium. And that means blood flow can be a whole lot more efficient, getting rid of some of that. So because of all of those things, right, we then, when we wake, have restored performance for activities. Metabolic load has been less, so we've recharged. Now we're ready to go ahead and actually engage in our activities. And then also, there's an improved chance for neuroplasticity. So all of the connections that your brain is making as you learn new things, develop new skills, hone skills you already have, and get better at them. And then when we talk about psychosocial and psychosomatic pain disorders, one of the hallmarks is actually trying to take advantage of neuroplasticity as we educate to essentially reprogram the way people are considering and concerning pain. And that all is improved with higher sleep quality. So current guidelines suggest adults should achieve somewhere between 7 and 8 hours of sleep per night. Notice it says should. If you don't feel like you're, subpar, that's a goal, and that's what we can recommend to people. If you're getting 2 to 3 hours of sleep a night, see me afterwards and talk a little bit. All right, so what? I'm still not sure what this has to do with PT practice. Well, like we said, sleep is a behaviorally regulated drive that works across multiple systems. We know from what we've learned over the past couple of years that pain is a physical and emotional together sign of bodily harm that strongly motivates our behavior. Now, what's interesting is we need both of those things, and they can exist symbiotically. We can have pain and sleep, and we need them both for survival. We need them both to kind of work together. However, chronic impairments in the systems that regulate either pain or sleep can have a broad and negative impact on health and well-being across the board, regardless of age, gender, etc. So sleep and pain are necessary, but necessary in the appropriate way, and they can be abused and have adverse interactions. So how adverse? Well, insomnia in a lot of this literature is sort of this catch-all word that they toss in there to just say abnormal sleep patterns or disorders, right? So we're going to kind of use it interchangeably like they do in a lot of this research. That's a prevalent condition, right? This abnormal sleep pattern is a prevalent condition affecting between 9 and 12% of the adult population on a chronic basis, right? So that means 1 out of every 10 people listening to me is going to have this condition. And at least half of those people listening to me will also have chronic pain because of their insomnia, or in addition to their insomnia. If we look at that equation from the other way, somewhere between 67 and 88% of people who suffer from chronic pain will also present with sleep complaints, right? So these two are so tightly linked here. And fibromyalgia, that chronic pain, again, depending on who's writing the research, they use the word fibromyalgia as a catch-all term. We try to use better language than that in the rehab world, but that's what the literature says that I'm referencing. So you're going to see some of those words in there. But that fibromyalgia category affects approximately 4 million Americans every year and is associated with $50 billion a year in healthcare costs just in the U.S. alone. Right? These are some of the highest ranking conditions in terms of disability, and they cost us a lot of money. Our vision, per the APTA, as therapists, is transforming society by optimizing movement to improve the human experience. So the bottom line is, if we're responsible for improving the human experience through function, we need to consider all of the available ways we can intervene and help to change their experience. Right? We care about patients' pain. That's what we're employed to do for the most part, especially in outpatient orthopedic practice. However, if we are missing some of these other nuances like sleep, the topic of today's discussion, I don't think we're doing a good enough job. So that's really why we're digging into this today. Let's check back in with Cindy. Cindy, after an extensive reconfiguring of my approach to her care, I kind of started to think, you know what, this seems more psychosocial. There's a lot of pain and dysfunction here. There's abnormal pain behaviors here. Let's dig a little bit more into this. So I decided to take a deeper dive into her day-to-day experiences and started learning some interesting things, some of it good, some of it bad. She's pretty lonely. She doesn't really have anyone to talk to. She ends up calling her 23-year-old son almost every day just for some interaction with somebody. She's also very anxious. A large part of that was related to COVID, but she also has this constant anxiety of what other people are thinking of her. Now, here's a good thing. She recently moved into a new apartment. She's by herself, and she's really excited about it. That was a goal of hers. That's something she had really wanted to do ever since she was younger, and she was finally able to succeed in doing that. And she knows that she should kind of keep that train rolling. She should go find a job. She's just never up to it. She always has an excuse for why she didn't get around to it today. I'll do it tomorrow, right? I'll do it next week. She spends a lot of time on her phone. Again, she's lonely. right? And that often happens late into the night, sometimes up to 2 in the morning, and she doesn't even realize it's that late. So she's starting to demonstrate some of these abnormal behaviors that we're concerned about. Abnormal behaviors like what? Let's dive into this a little bit. Let's put some meat on these bones. What are sleep disorders? What are your patients experiencing? There's two categories. There are the psychological or the non-organic, insomnias that we're going to really mostly be talking about. It's also important to point out that there are physiological sleep disorders, things like sleep apnea, that can be an organic reason you're having problems with your sleep. Other problems like circadian rhythm issues. If you have difficulty, you're on shift work, or you live in a place where the sun never turns off or it never turns on. If you're visually impaired, you can have circadian rhythm problems that can adversely affect your sleep. We still have some room to intervene with some of these individuals, but we're going to separate those categories out a little bit because there is an actual somatic reason, a physical, organic reason why that sleep disturbance is happening. Whereas in what we'd call traditional insomnia, that is not the case, right? So the ICD-10, which in case anyone wants to know, is F51.0. So just go ahead and drop that the next time. They describe this as a disturbance of sleep onset or sleep maintenance, and poor sleep quality, right? So it's a combination of not being able to fall asleep and or not being able to stay asleep. And when I am asleep, I don't sleep well. And that disturbance has to occur repetitively, right? And according to the ICD-10, for the diagnosis to stick, it has to be at least 3 times per week over the course of a full month. The other element of this is more psychological. Again, the person focuses on that sleep disorder and worries about the negative consequences of that. And I'm not just talking about someone who, I didn't get enough sleep today and, complains at work the next day. That's not what we're talking about. We're talking about the people whose entire attitude is determined by how well they sleep the night before, and they are so focused on it that it becomes one of the only things they perseverate on it. And then the consequence of all this is they don't, they suffer. They don't have the ability to do their daily performance the way they'd like to, and they pay for it. Right. So that's how the ICD-10 defines insomnia. You have to meet these conditions in order to officially get the label. The European Sleep and Research Center goes a little further. They define non-organic insomnia, referring to the fact that the disorder does not have a specific recognizable somatic disorder at its core. So we sort of alluded to that already. And that diagnosis, non-organic insomnia, is based solely on the subjective experience of the patient, right? So yeah, we're talking about sleep onset, sleep latency, how long can you stay asleep? How long does it take to fall asleep? Right. But in order to get this diagnosis, you don't need to have measurable numbers. It has to be the patient reporting that they're having trouble with it. That's an interesting distinction, right? That, again, lines a little bit more up with the psychological element of this. No quantitative criteria is necessary, right? So despite this term, recent evidence has documented that even though you have a non-organic insomnia that is a psychological or psychosomatic problem, it actually can have biological consequences as a result of it. We're going to go a little bit more into the psychological piece of this here and look at what the DSM-5 says about this, and the ICSD-3. They have essentially the same definition. So a disturbance of sleep or sleep quality, we checked that one. We've seen that before. One or more multiple effects, having suffering because of it. We've seen that before. The next one's the one that dives a little bit further, and I want to focus on. There's both adequate opportunity and environment for sleep. So I think I would miss a step here if I didn't make sure I pointed out there are some people in our communities who do not have a good environment or a safe environment to be able to sleep, right? So as we start to integrate this into our care, remember that there are individuals who either live somewhere it's too loud, or they can't get the room dark enough, or even a little bit more sinister, they're afraid of harm for either themselves or someone they care about if they let themselves fall asleep. Those individuals exist in our community. So try to be mindful of that as you are starting to approach this subject. Be aware that we can sometimes run into some of this, and we will probably need to engage somebody else in the patient's care if that is the case. And then the other thing that the DSM-5 says that you don't see in some of those other categories or labels is that this difficulty, sleep-wake difficulty, cannot better be explained by something else. So again, that refers back to some of the more organic considerations. All right, so we've talked about what a sleep disorder is. What things do sleep disorders affect, right? What's made better? What's made worse? What can actually impact this sleep pattern that we're having here? Like, how does our environment shape that? So there's 3 sets of factors that can apply and affect sleep, and they're often broken down into the 3 Ps. You've got predisposing factors, precipitating factors, and perpetuating factors. So the predisposing factors are the ones that are kind of set you up for failure, right? If they line up the wrong way. Things like your genetics, your personality characteristics, the presence of other disorders of mental health, depression, anxiety, or other more advanced psychoses, things like multiple personality disorder, that kind of thing. Sometimes patients are just sort of in a position where that's their lot in life, and so they're kind of already set up for failure, if you will, which can then lead to the progression of some of these other things. So then the precipitating factors that can affect sleep quality kind of say, okay, you're set up for this, or maybe you're not, but just perfect storm of conditions. Now here's what sort of triggered it. Here's where the problem started. So that's things like the patient's level of pain. Research has been indicating that we can use an individual's current level of pain. So pain today can predict whether or not they're likely to have insomnia 2 years from now, right? This is, of course, without intervention, right? So if one of our patients comes in with a new development of some of these abnormal pain behaviors, if we did nothing, we can reliably predict they'll probably have an insomnia problem in 2023. And it will probably have happened sooner than that, and they'll still be struggling with it. Additionally, stressors in your life, right? These are all our yellow flags, our blue flags, our job concerns, money concerns, relationship problems, safety, again, like we mentioned earlier. All of these things can start to pile on top and start this transition, this kind of downward slide into a sleep disorder. Again, referencing back some of the things that are factors that make this a problem, but are less psychological. Your job, or if you're visually impaired, some of those things that just they can be the reason someone develops a sleep disorder, but they're not really necessarily things we can influence as easily. They're kind of external circumstances. And then perpetuating factors. So this is really where we intervene, right? These are the things that the patient is doing that are not giving them the opportunity to get some relief, right? So that's including things like opioid use or other pain medications, but opioids are the big one. It's interesting that opioid use actually has a very direct relationship with someone's pain and with someone's sleep, right? It can increase lighter sleep or reduce deep sleep, or both at the same time. And that's in patients with chronic widespread pain, or as you can see, with low pain. So that's that kind of education we need to start providing, helping patients connect these dots, right? I'm doing this thing and it's affecting this thing. It's affecting my ability to sleep. I would never have thought those two were connected. Giving them the opportunity to start to put some of these pieces together themselves, that's where we really influence meaningful change. Some of the other things that we can start to intervene on are their coping strategies, right? For example, you didn't sleep well the night before. You're going to try and take like 3 naps today to kind of catch up and get yourself back on track. That's actually an adverse behavior. and we're going to need to start to intervene. So that's where some of the sleep hygiene comes into play, changing some of these factors. This maladaptive focus on sleep as well is another thing that we can start to encourage the patients away from, right? So the perpetuating factors are really where we have the most leverage to influence and to help the patients change. Additionally, here's a list of, and we're not going to go through this, but here's a list of different comorbidities and risk factors that you may see in patients who present with some of these problems. So as you try and yourself start to paint clinical pictures and figure out whether or not the patient you're dealing with is experiencing some of these things and whether they might be a good candidate for some sleep hygiene, some sleep coaching, this can help you paint that picture, start to piece some of this together. If they have the presence of some of these other factors, there is a significant chance that this is going to be a problem for them. So that's how sleep is affected. What does sleep do to the person, right? Or lack thereof. We mentioned a little bit of it in our introduction, but let's get into some of the ones that actually matter to us. Sleep quality has the ability to affect our cognition on the entire organism level, not just, specific thought processes, right? Mental capacity wide, that sleep has the ability to negatively or positively affect that. And actually can be a precipitating factor for things like the development or progression of dementia. Poor sleep quality has been proven to have a direct link to that, and it can actually accelerate that process. Additionally, our activity tolerance, the ability to maintain not just our physical endurance, but also our mood while we're at work or throughout the day as we're doing our daily activities. Our quality of life throughout our day. If we haven't slept well, we tend not to have the energy to get through a full day like we would like to. Again, let's go back to this. Sleep quality has the ability to affect our perception of pain. So we were talking about how if someone has the presence of a chronic pain disorder, we can predict whether or not they'll have insomnia. That relationship works the other way around too. If someone has the presence of insomnia, we can also reliably predict that they will have either a new incident or an exacerbation of their chronic pain. So that train goes both ways. And we can use that to our advantage. If we see one, suspect the other. Sleep quality also has the ability to affect cardiovascular health. Individuals with this OSA is obstructive sleep apnea or insomnia, both are at greater risk for cardiovascular, cerebrovascular, metabolic problems, all across the board, right? They're all impacted by sleep or lack thereof. And then additionally, weight gain, obesity, some other comorbidities that can lead to problems down the line. Ultimately indicating that our mortality rate is affected by sleep, in addition to age and gender and other medical concerns. All right, so that's a lot of information, and you're sitting there by now saying, okay, Steve, I get it, sleep matters. So what am I going to do about it, right? Well, let's dive in a little bit to what the literature has to say about this, right? There are thousands and thousands of studies that have been done on how, what sleep does and how we can address it. There are thousands of studies that have been done on what pain is, how it presents, what we can do to address it. There's not a ton that's been done about the two together, except for this one that we're going to look at here. This actually came out last year, and this is pretty much the most succinct model for how we can progress and help our patients intervene on both of these fronts at the same time. And it's like the perfect piece to our puzzle here. So we're going to go through it. It's called the Sleep and Pain Interventions, or the SPIN trial. So this group compared the efficacy of cognitive behavioral therapies for both sleep and pain, and they compared them to a control group. So they found 113 patients who had already had a diagnosis or a label of fibromyalgia and insomnia together. All 113 patients fit that category. And they randomized them across 3 groups. There were 2 intervention groups and 1 control group. So the intervention groups, one had received 8 weeks of cognitive behavioral therapy targeting their sleep problem. One received 8 weeks of cognitive behavioral therapy targeting specifically their pain problem. And then they had a control group, which was basically, standard medical care. Here's some medications, here's some recommendations, try and get some more exercise, it'll be good for you, and then let them kind of subside like that without much more intervention. So they measured a lot of outcomes in this study. They measured physical data. So they have this measure of actigraphy, which is the measure of movement. So that's basically like if you wear your Fitbit to bed and you wake up the next morning and it can show you how well you slept based on how much you were rolling around. And then polysomnography, which is a more traditional, when someone says they're going for a sleep study, right? That's typically what they're talking about. That's a conversation of, here's what your brain waves were doing. Here's, we had some video footage of how you were sleeping and the positions you were in. They kind of combine all that. So they measured all of those things and then compiled it with self-report measures, sleep length and quality, and then self-reports on pain and on mood. So the patients had a lot of subjective feedback to give to the examiners as they went through this. They measured these pre and post treatment as well as 6-month follow-up for all 3 groups. And the results were fairly interesting. They found that there was significant improvement in both sleep quality and efficiency for both cognitive behavioral therapy groups, regardless of the focus of the group. Whether you were learning about pain or about sleep, you reported improved sleep quality and efficiency at both right after the treatment was over and at 6 months. Participants in both treatment groups also reported less morning pain at both immediately after treatment and 6 months. And the participants in both groups also reported fewer depressive episodes at post-treatment and 6 months. So we hit all 3 factors. We hit improvements on sleep, we hit improvements on pain, and we actually got improvements on mood, regardless of the cognitive behavioral therapy you were receiving. Now, the interesting thing was there was almost no change seen in any of the physical studies, any of the physical measures. The patients appeared to move around the same. They appeared to be asleep for the same amount of time. They saw no changes in that category at all. So as they sort of discussed this, they thought that sort of like what we're saying now, it's really interesting that regardless of your intervention, you were going to demonstrate improvement in a majority of the sleep outcomes, or at least the subjective ones, with obviously greater improvements seen in the sleep-focused group, but both groups hit the significant milestone, right? And then the only thing that was different between cognitive behavioral therapy for the sleep group versus the pain group, the sleep group had decreased dysfunctional beliefs about their pain after the end of the study. So they thought about, decreased dysfunctional beliefs about their sleep. So they thought about their sleep in a more positive way after receiving cognitive behavioral therapy than anyone else in any of the other groups did. Again, they noted that almost absent change in the physical measures indicates that the benefits of these interventions is cognitive change, and that cognitive benefits are significant in the overall patient outcome. So it doesn't really matter if it looks like the patient is still moving around. If the patient tells you that they feel better, they've slept better, their sleep was longer, etc., that's success, right? Because that's really what the patient cares about. Their limitations, it was a small sample size for an initial study like this. 113 is not shabby, but for the number of things they were trying to measure all at once, it was a little underpowered. And they also noted that in terms of the pain responses, there is a floor effect, because they didn't really talk about current level of pain as an inclusion or exclusion criteria. So someone could have showed up with the label of fibromyalgia and said, yeah, I have that, but really they were at 1 or 2 out of 10 pain. And then when someone says, hey, did you improve? They go, well, not really, but I wasn't bad to start with. So they didn't account for that, and that limits their findings a little bit. Also, their large number of outcomes meant the consistent participation was tough. But nonetheless, the findings were incredibly informative in terms of how we can and why we should apply some of these factors. So let's check back in with Cindy. When we last left our hero, she was clearly demonstrating a number of the behavioral and functional characteristics of an abnormal sleep disorder. So I elected to broach the subject. She was very hesitant and almost got defensive about it. But I thought, you know what, I'm going to push a little bit here, because if I can help her help herself, that's going to be really important, and we can try and improve her sleep hygiene. Right. So what is sleep hygiene? Why do I keep using that word in particular? That term, sleep hygiene, was originally defined back in the 90s, early 90s, by a Dr. Howery. And he defined it as a scientifically supported set of rules and guidelines for how to get better sleep, which are based on a substantial body of clinical research. So he sort of looked around and said, we've done all this research on sleep. How do we actually make it matter to the people? Right. And so he thought of the word hygiene almost as if we're cleaning up, we're making patients' life choices healthier, just with the emphasis on how they're sleeping and what they do for themselves to make that as good as possible. So he developed this multimodal approach to changing a patient's sleep experience. So here's some of the things that we are going to be able to change. And these are the recommendations that you can start giving to your patients about how they can make improvements for themselves in regards to sleep. A lot of this is borrowed from Dr. Howery's work and is then combined with the work of people like Dr. Adrienne Lowe, who write a lot about this experience from the pain side of things, and they have a lot of practical knowledge and insight that we can use as our resource. So this is kind of a combination of both of their recommendations. Changes to the environment is a big one. That's probably one of the easiest things we can encourage the patients to do. Shut off your lights, turn off your television. Don't try and sleep with them on. Also, cool a room, right? Make the environment more comfortable. Don't have your children or your animals in bed, right? That can not seem like that big a deal in the moment, right? But if you make that a pattern, it can actually adversely affect your sleep. Those of us who don't sleep with children or animals in bed are like, yeah, duh. But that, circumstances can lead to that becoming a habit. We want to try and encourage people to kind of back off of that a little bit. You want to start developing other appropriate habits, and this is what we can start to encourage in our patients, right? I mentioned shut off the lights and the television, right? That's an environmental thing, but it is also a habit thing. If you're used to watching TV as you fall asleep, it can be weird to try and fall asleep without it. So we have to start to, that's going to take some repetition for that to really stick. You want to encourage the patient to limit their naps during the day. And to limit both caffeine and alcohol intake. And then also limit water intake, right? So fluids in general, you're going to have to get up and use the bathroom more frequently. But then specific chemicals, right, like alcohol or caffeine can actually, make they have the adverse effects on your cognitive activity, making true, genuine, restful sleep more difficult. And now we'll get into some deeper behavioral changes with a little bit more of a psychological element to it. I have found a lot of success in encouraging patients to start a sleep diary, having them write down not just how they slept that night, perseverate on that, but then also add what else happened throughout the day. What did you do? When did you try and go to bed? What did you do the day before? Did you exercise that day? Did you eat what was your diet like? And they can start to use the pattern of information they see to help themselves problem solve. Encourage regular physical activity. This is our job, to encourage physical activity just on a daily basis. So we know how challenging that is. But using sleep as another kind of connect the dots moment for your patient can be a really good way to encourage them. Hey, listen, take this seriously, right? And then this is another one. I like this one a lot. I think I might actually start to use it for myself. Parking your ideas. Have a pen and pad next to the table or next to the bed so that you can write down whatever you're ruminating on, right? If you have something that you're trying to problem solve, it's keeping you up at night. If you all of a sudden wake up at 1 in the morning, remembering, rats, I have to, take my kids to daycare tomorrow and I had forgotten about it, or those kinds of things. If you have an opportunity to write it down, now that it's permanently placed somewhere, the brain is given permission subconsciously to essentially let go of that idea so that it doesn't feel compelled to remember it by the time you wake up in the morning. And that can allow you to go back to sleep significantly easier. Here's another interesting one. Stay in bed. So if you have a patient who's finding that it's really, really hard for them to fall asleep until really late at night, or if they find themselves waking up super early in the morning and they don't know why, you can encourage them to say, listen, until your normal waking up time, stay where you are. Keep your eyes closed. You might not be sleeping, but if you do that with enough repetition, those closed eye sessions can translate into actual sleep. Now, the caveat to that is this is intended to be done in the context of a normal sleep-wake schedule. If someone says, well, I'll just stay in bed because I didn't sleep well the night before, and I'm going to stay in bed till almost noon, that's not what we're talking about. So there are some patients where that recommendation may actually be detrimental. Encouraging meditation, stretching, deep breathing exercises, similar to some of the other cognitive behavioral approaches to other types of pain and pain behaviors, that works here too. And the last one I think is really important here: have the patient problem solve. Put them in the driver's seat. Let them see the cause and effect relationship and start to actually make some of these changes lasting because they want them. They see the value in it if you allow them to be a part of the solution and the discovery here. So let's wrap up with our case example, right? Cindy was, like I said, originally hesitant, but since we had developed some rapport, she was willing to give it a shot. And here are the things that worked for her. She stopped using her phone in the bedroom. She didn't have a TV, but she was using her phone. She picked a defined sleep and wake time. She stopped taking naps during the day unless she could absolutely not avoid it at all. And she started journaling about her pain and her sleep. And she still uses those journals. She will occasionally go through and read where she was 2 months ago and remind herself, wow, I've come a long way. And she's been able to start to pick some of these pieces up and put them into the puzzle on her own based on how she's written these things down and made it real for herself. And sure enough, implementing these changes ended up helping Cindy experience less fatigue and less pain. So she's now out interviewing for jobs. She bought herself a car so she could be more active in the community. She is continuing to struggle with chronic pain, and she probably will, given her background. But each effective treatment steps her in the right direction. And like I said earlier, I was able to help her to help herself by implementing some of these considerations. So practically, as we wrap this up, here's how you make the most of this. Language and behavior education, like it says here, is necessary, but you need a method. Right? We can't just have a list of all of the sleep rules and hand them to every patient in a pamphlet because no one's going to follow it, right? It needs to be specific. You need to do the digging to figure out which behaviors the patient is exhibiting and how you could intervene on them. And really, research is showing that people can benefit from no more than 3 or 4 rules at any given time anyway. So if you give them a list of 10, it's going to go right over their head. I would think 3 or 4 may even be a little high. I'd stick with 1 or 2 to start and just try and see if they stick. Encourage some repetition. If it's just not working, it is okay to step back and say, okay, let's try something else and move away from it, maybe come back to it later. A method that I have seen written a lot of different places and have started to use myself is to develop a checklist for patients. And the idea is they add 1 new concept at a time. Right. So once they feel like you can write out, okay, we're going to try and work on all 8 of these or 6 of these or 4 of these, whichever you think are going to be the most effective for that person. Say, start with number 1. Don't move on to number 2 until you feel like number 1 has really worked for you. And then once they have succeeded with, okay, yes, I don't turn the TV on. I don't even try to turn the TV on anymore. Good. Now move on to number 2. Drink less water or whatever, right? Trying to find a way that the patient, again, gets put in the driver's seat themselves so that they have the ownership of this progression is the most effective way we can intervene. In conclusion, right, let's dock this showboat. There is a definite need for this. We know there's a definite need as healthcare workers to address pain. That's an epidemic that's running wild, and the more of us are learning about it, more of us are learning how to intervene on it, and that needs to continue to happen. But remember, recognize the importance of some of the nuances of the greater concept of pain and abnormal pain behaviors, one of which is sleep. These sleep disorders are so closely linked to pain that you can't differentiate between the two, especially if they're both present. And so the research indicates that education and behavior modification can and will have a significant positive impact on patients' sleep and consequently patients' pain. So as doctors of physical therapy, as physical therapy assistants, as providers in this setting, we need to participate in this, right? It doesn't have to be super elaborate. It just needs to be something we choose to care about. And I think that that's really going to step us all a little bit further in the right direction and give us all more tools that we can use to be successful in caring for these patients. So there are quite a few references here, but I am open to taking questions now if anyone has any. Do I have to do anything with this?
Ask them to unmute themselves to ask.
Ask them to unmute themselves to ask. Okay, if you have questions, your job is to unmute yourself and then ask a question, please. Or type it in the chat. Steve is watching the chat.
So I'll ask a question.
Sure.
If with your other patients outside of Cindy,
Mhm.
what would you say has been the most effective? You know, if you had one trick, one tip,
okay.
what would be your one thing that seems to have worked the most with the most number of people?
So if you couldn't hear that, Steve's question was, if you had to pick one of those tips that seems to be the most effective most of the time, right? What's the one trick that you always jump to first when you try and intervene in this case? I would say it's kind of a toss-up between just basic fundamental environment changes, like making sure your room is dark and cool, and things like not having your dog in bed with you. That seems to be a pretty easy one for patients to start with, and even just that gives them some ownership. Or honestly, the other one is the journaling, is having patients start to spend some time writing out their experiences, right? The subjective reports, those research studies were showing that really where we see success is with patients' subjective experience. So start them on that right away. Have them actually spend the time, even if it's only like 3 lines. Yeah, I exercised today. I fell asleep faster. I stayed asleep for 6 hours. Okay, well, that's enough data that you can start to see a pattern develop if you were to do that for a week or a month or something like that. So it's a good question.
Thank you.
Do you ever refer for psych services or counseling in conjunction with like chronic pain patients?
Have I wanted to? Yes, absolutely. I have found that to be incredibly challenging, especially within the network. I often don't, frankly, get much further than recommending it to a patient and saying, let's dive into this. And then if I want to make that push, I usually get the PCP involved because I think they somehow have a little bit better leverage to get the patient into somewhere that needs that can meet those needs. I really haven't referred that frequently because I think a lot of times patients that need that kind of care are already receiving it. That ends up being my biggest experience. Is I'll chat with someone about some of their other care that's simultaneously happening, and they're already working with counselors, they're already working with psychologists or psychiatrists, they're already meeting in groups and going through some of these cognitive behavioral things, because either their PCP or another provider also caught it and got them involved in it pretty quickly. Does that answer your question?
Yes, it does. Thanks. That's pretty much my approach too. Thank you.
Mm-hmm. Not a whole lot happening in the chat. Okay. Well, thanks everybody. I appreciate it.
And so again, make sure that you sign in and sign out with your login so that we can give you credit for today. And please feel free to email either me or Dr. Betz with any further questions. Thank you very much for joining in today. Have a great week.